That's the second time you finish your, you come and open, exit. Again, as you are closing, those are 4 times. And everywhere you are moving, the potential for infection and reinfection increases. So hand hygiene with soap and water, that's available, that's affordable, and it's routine. If in a high-profile area like this one, you can use Saraya hand sanitizer, which is alcohol-based, and do it well. We are already seeing cases of outside there, and the attitude is still showing up, even in the high-profile people. You want to do it again? You want to do it me again? Yeah, very, very, very much, because the exposure is almost around us, and we can always prevent this by doing it and again and again and again and again. Then coughing practices, we can also improve them. And now I think we would also have encouraged people to put on long sleeve clothes such that you have good coughing reflexes, mean that are ending up within your elbow. So if you want to cough around your neighbor today, just flex your hand, your elbow around your nose and cough properly and ensure that it's very good enclosure. And then temperature monitoring. You can actually know when your temperature is high by either touching or having an equipment to take your temperature. If it's about 37.5 degrees Celsius, quickly rush to a health specialist to attend to you. And avoiding dehydration. So drink a lot of that water. Don't leave the water covered. Drink and keep your throat moist. This is a respiratory tract infection, so it quickly affects your throat. And at the gates, we are having a thermal flash, which we are using at a distance of 1 meter, but we come to about 5 centimeters close to your body. So it's not a gun, it's just for temperature monitoring. And don't get scared of it. It may not be affordable in our health facility, in our offices, but you can have another method of knowing your temperature. And treatment, when you are identified to have a disease, please do not again run away to areas where you think you can become a threat, like our parliamentarian did, confessing on the floor of parliament that he already came from an area. Then we had to fly him away. And without even asking one time, we didn't see anyone escorting him precautiously to take him to an area of isolation. And we don't actually know whether he went to isolate himself. So when we say we are isolating, it's part of the control methods and measures to avoid you reinfecting other people or infecting or becoming a threat to other people. Thank you so much for showing up for this dialogue, and we hope you enjoy to the maximum. Thank you.
Thank you, Daniel Auren, who is in charge of this event. He forgot to talk about the microphone. He has just given me this microphone. I don't know whether I need to. He needs to disinfect himself. He had gloves when he got it. Okay, all right. So it looks like we are safe. And I hope by the time we leave, we shall have a new greeting. He didn't talk about greetings. We've been using elbows all the way. So I hope by the time we leave, we will know whether the elbows are safe or if we should adopt a new greeting in this event. So we are going to get started as we wait for the rest of the panelists in the interest of time, so that we can have enough time at the end to have a dialogue. My name is Rhoda Wanyenze. I'm a Dean at the School of Public Health, and I will be moderating this session. I know you have another moderator on the agenda that you have. I'm not Professor David Serada, I'm Rhoda Wanyenze. So welcome once again, and welcome colleagues who are joining us online. We are live streaming, and we have people joining us from several districts. We have people joining us from several institutions as well. We did this deliberately so that we don't have everybody that feels they need to know about Corona to come here, but rather to be able to join us from a distance. So the first item on the agenda was for me to do welcome remarks, and I'm also the moderator. But I will start by speaking about why we thought it was important for us to have this event. First, there is so much conflicting information going on about Corona. Do you feel the same way I do? Have you had WhatsApp or seen WhatsApp messages that say that Africans are immune? Hello? You've seen it. Have you forwarded it to anyone? I hear yes, and I also hear no. So I hope by the time we leave here, we will continue tweeting and WhatsApping, but we will send the right messages. One of the issues we were concerned about is that these messages might actually be detrimental. We need to know what we should do at individual level. We need to know what we can contribute. We need to know what each of our institutions should contribute. We need to know the right messages about Corona. So we thought it was high time we got together like experts in the field. The Ministry of Health, we have WHO, we have CDC, we have AFENET here, we have all of you who are experts in your own right. We need to coin one message and be consistent about what we are sending out. We've also been seeing several messages around what is the right action to take. For example, we've seen statements from countries that say we are not closing our borders because we think it doesn't work. Some are saying it works, and there's a lot of convincing evidence about that. We've also been seeing messages around, please use a mask. Some people are saying masks don't work. Have you heard that? So what should we do? What is it that's going to work? We wanted that this information is widely disseminated and that we are all able to live with one message that we can share with others. The other reason why we thought this is important is we are dealing with a monster in Corona. We can't see it, but it's a real monster. Do you feel the same way? This Ministry of Health and partners that have a key stake in this doing to keep us safe. What is it that they would like us to know beyond some of the flyers that we are seeing, so that we can also add value? Because Corona is a complex issue and it's not just a health issue. So it's not just about Ministry of Health. What more should we do? What role do we have? There's our colleagues from the media. What should you be writing about? What's your role? So we thought it would really be important for us to get together and hear what the Ministry of Health has in plan, but also be able to ask questions that might add value to the plan for the Ministry of Health. This is a complex condition. We have not had it before. And certainly we cannot say the plans we have are perfect. What more do you think needs to be done yourselves here today? If you have questions, if you have suggestions, please bring them up. This was the other purpose for getting together, that we can add value to the plans that the Ministry of Health has so that we can strengthen our response and be able to protect Ugandans as well as the people across the world, make our contribution to stopping this condition. Finally, we also have seen the messages that have been coming around. From the Ministry of Health, we've seen messages from CDC, from WHO, and from all the global stakeholders in this. But so many questions are coming that require that we probably have a second generation of messages. People are actually thinking, should I run away from some people who look a certain way? If you actually sneezed a bit around this room, we might actually run faster than a bullet. But so now we fear someone sneezing more than we fear someone shooting a gun. So, and then if you heard that anyone near you has just landed from a certain country, would you pack your bags and go? So there's a lot of things happening and we are all confused. We want some messages that are uniform to guide us so that we can do better. And that might call for a second generation of messages responding to the concerns we have, the stigma that is growing so fast around people who have certain characteristics. This is really growing. So in a nutshell, this is the reason why we thought this dialogue would be important, although it's coming at a time when we had a debate, should we even have it at all if we are going to have a physical meeting, a mass gathering, or should we actually do only live streaming? So we thought we should have a bit of both. We have very few people here, but we have the majority of the people joining us online so that we can reach out to more people without having everyone here. So this is the reason why we thought this was really important. And I need to say that this is not just about the School of Public Health, but this meeting has been organized by partners who got together and thought that this would be a very useful discussion to have. So we need to acknowledge the WHO that is a partner in this. So it's not about Makerere, because we have organized this together with a team from WHO. We have also had Ministry of Health, and I'm glad the Director General has now joined us, and the Commissioner for Surveillance and Disease Response. I hope I've got the title right. We have organized this event jointly because we all need to come together, and AFENET, the Africa Field Epidemiology Network, is a partner in this because they are doing issues related to surveillance and disease response, detection and response across the African continent. So they have been a partner in this. And we thought that we, together with all of you here, will live with a common message and a strong message that can help us stem Corona. And as I end, I just want to say and to challenge you that Corona is not about Ministry of Health, because most of us are saying, Ministry of Health, what have they done? And we are actually criticizing, and we are criticizing. But Corona is for all of us to prevent. When we live here, I hope the message will be strong, that each and every person here and out there, in Makerere, we have a mass gathering every day, Ministry of Health. Dr. Mwebesa, we have a mass gathering every day in the name of lectures. So, and I know other universities, I can see you, the dean is here for the Faculty of Medicine. We have mass gatherings every day. So all of us need to live knowing that we have a role to play in terms of how we can protect the people within our institutions, within our homes, how we can protect ourselves, and that we can go with a message stronger than just looking upon the Ministry of Health to resolve this issue alone. So this is a summary of why we are here, and I hope our colleagues online, you do realize too that you have a role to play wherever you are, even if you're not present here with us. We are happy to have you join us here. So thank you so much. Those were supposed to be my remarks with someone else moderating, but I'm also now the moderator. But I would like to say that that has come to an end in terms of the remarks that I thought I should make to welcome everyone here. We will now move on to get the opening remarks from the Director General, Dr. Mwebesa, who is representing the Minister, the Director General, Ministry of Health, Dr. Mwebesa. Is going to come and speak to us on behalf of the Ministry of Health to let us know what is going on there as well, and open this, and then we will immediately move on to the presentation from the WHO country representative.
Since I'm representing the minister, I think I hope to take a podium and talk as a minister. The session, I had anticipated Professor David. This is Professor Roda. I know he came from US 2 days ago. A day ago, he's supposed to be quarantined, but they had given him exemption. So I don't know why he feared, but it's okay. You're following the rules. Self-quarantine. That's good. So I'm supposed to make comments on behalf of the Minister, Honorable Joyce Morebu, who is traveled to Arua for a certain different assignment. So the session chair, the Dean School of Public Health, they are 2 in 1, the WHO country representative, the CDC director, the executive director, AFNET, colleagues from Ministry of Health and Academia, development partners here present, religious leaders, and ladies and gentlemen. Good afternoon, ladies and gentlemen. As you've heard, I'm Webesa Henry. I'm the Director General, Ministry of Health, and I'm making these remarks and notes which have been given to me by the Minister to make them before you. As I've said, apology from the Minister. She's in Arua, and I'll be making a few comments, general comments on behalf of the Minister, and the details and the technical issues will be in my presentation, which I'll be giving. So these are broad issues on behalf of the Minister. Of course, there will be some intersection, some of the things I put them in my presentation, but these are generally the broad issues. First of all, she started Career College of Health Sciences, and in particular School of Public Health, for working closely with the Ministry of Health to dialogue and to discuss technical, saying where people are looking at this as an issue of Ministry of Health. This is not a problem of Ministry of Health. It is a cross-cutting issues. All of us are involved in it. The Ministry of Health, the academia, other sectors, because it's not only affecting the Ministry of Health, it is even affecting our economy very badly. So the stakeholders involved in this are really very many. We also wish to thank participants for sparing time to come and contribute to these discussions on how best we can protect our country against this coronavirus disease. As I said, we are all stakeholders, we are all involved, and we all contribute to this important discussion, and we all contribute to protecting our people against the disease. This is the policymakers, the implementers, the funders, and other stakeholders. So we are here to guide each other and not for blame games. And on the same way, as the Minister of Health, we are not here even to be on defensive. We shall take it in good faith as long as you guide us on the way forward. We also don't want situations where people come and start criticizing without giving a solution. So that's why it is called a dialogue. You comment what you have seen, what we are doing, what is not going right, but you must guide us on how best we can do it. And I can assure you, we shall take it in good faith, and we shall listen to you for all intents and purposes. We want to assure you that the Ministry of Health has put in place resilient systems which have been built over time to address this problem. We want to, of course, we see very many people are anxious, there's a lot of anxiety, there's a lot of fear. For us as a Ministry of Health, really we've been going through this for quite some time. Recently, we've been going through the Marburg. First of all, the Ebola more recently from the DRC. And we've literally been going through the same system. And we've been going through the same preparedness, the same plans, and everything. Before that, we were going through Marburg, exactly the same thing. The structures we have in place are exactly the same. So over time, we've really built capacity across the country to address such challenges. Well, this is a new burden, a new problem, but the mechanisms of addressing the problems really rely on the same structures. So in this way, together with our partners who have supported us tremendously, we have developed capacity for surveillance in this country, very good system of Ebola, contacts from DRC, but systems for surveillance who could track those patients, not patients as such, but contacts from DRC. They would be in Kampala, we would track them in Katwe, we would track them across the country, and would identify them and find them, either vaccinate them or monitor them and follow them all the time. So we have the capacity. We have the capacity for lab investigations in real time that we can get results in a very short time. In the past, we used to take these samples across the country. We take them CDC, Atlanta, South Africa, but now we do it here. Even for coronavirus, we can do it here and give you results in the next few hours. We have capacity for case management that we can manage cases, much as this is a new condition, but it is the same principles of infection prevention, supportive treatment, and case management. We have capacity for risk communication and behavior change communication, which we have been doing before. We have capacity for psychosocial support. We have capacity for logistics management. We even have capacity for safe and dignified burial in the event that we lose one of the conditions. So we are building on this capacity, which we have built over years, to manage even the COVID-19. And we'll appreciate that but we also appreciate that this is a new condition. It comes with new challenges. There are a few more things to learn. But as I have said, the structures and the systems are the same. It is not like we'll be starting afresh, but for us, we look at it as one of those high-risk conditions that we have always managed, and we can manage the same way, using the same structures that we have built over time. But I also want to emphasize that the biggest effort or the biggest problem we have with this is that it is a new disease, a new condition. We have not developed immunity in this country. And it has the potential to overwhelm, in which case you can get very many cases. You realize that when we had Ebola, sometimes you could get 1, 2, 3 cases. But in this case, there's a potential. We have different scenarios. There's a potential. We have 3 scenarios that we can continue preventing its disease and we shall have 0 cases. That's the best case scenario. But we also have a scenario where we can have few cases, 1 to 10, and those we can manage in our isolation centers in Entebbe and in Nakuru. In Entebbe we have 25 beds, in Nakuru we have 10 beds. But we also have such scenario where we can be overwhelmed. You get 50, 100 cases in this country. That's a situation which we have. And of course, we must admit that would be overwhelming and that would be tough for us. And I don't think we have those resources and those capacities, so certainly we'll have to call on our partners to assist us with such situations. So that would be the worst case scenario. In that case, we'll be looking at Mulago as the isolation center for that kind of overwhelming situation. We are also aware that the disease condition present in different ways. About 80% are mild, about 13% are severe, but we also know the situation about 6% could be critical, requiring ICU. So in that situation, we'll be looking at Mulago for ICU facilities, but we can also confirm to you that we have the capacity in Mulago for ICUs, we have respirators, oxygen, and dialysis if required. But as I've told you again, it depends on the situation. If you are overwhelmed by 100 cases here, of course, the story would be a bit different. I also want to inform you that as a ministry, we are preparing a legal instrument, I think should be ready by now, that allows the minister to quarantine or give any directive she finds fit for the control. I remember when we were doing some measles, rubella measles, some lawyers were trying to make money out of us. And I'm sure some of them might be willing to start running nothing up and down with human rights and the like. Why are you quarantining me and the like? But we shall have a legal instrument that the Honorable Minister of Health can declare anything and can quarantine you or can direct you to leave the country as should be advised by the technical teams and by WHO using that legal instrument. In terms of local congregations, we have already been seeing that schools stop being visitations. We feel that we haven't reached that level as of now, because the situation changes every day. But as of now, we feel we haven't reached that situation. If it requires suspension of visitation and the like, the minister will advise accordingly. As of now, we feel visitations and some activities can go on as long as you follow our guidelines for mass gatherings. I saw as we are coming in here, for example, the guidelines for mass gatherings were being followed, and those are some of the things we expect schools to follow, or any other gatherings that are taking place in the country, including the church. Yesterday, we had very good discussions with the Religious Council of Uganda, where we had all the religious teams represented, and we are giving them guidelines on how they should handle churches and fellowships. Otherwise, people will even stop going to church. But such a gathering will continue to go on, provided they follow the guidelines for mass gathering. So visitations in schools will continue, even sports events should continue. The ministry has also released the advisory, and as I'll be presenting later, we have categorized countries, category 1, those which are very, very high risk. So far, I think we have about 16. And then category 2, which we are continuing with category 3, where we are comfortable. So, as our policy or as our guidelines, we are advising that we should avoid all non-essential travel to high-risk countries which are in category 1. And I think we shall be presenting them. Unfortunately, they include some of your favorite destinations where many of you travel to, like UK and US. So we strongly advise that for now you postpone those kind of visits to those countries. Likewise, we are advising through our missions abroad and even embassies here that visitors from those countries should postpone their visits to this country. Let's get it clear, we have not put a travel ban. We are advising them that they postpone their visits to this country. In the event they can't postpone their visit to this country, when they reach here, we shall quarantine them for 2 weeks. I'm sure many of you already know why we're talking about 2 weeks. Because if you get here and you don't have any symptoms, if you stay within 2 weeks, that's good time enough for us to monitor you. If you don't develop the symptoms or the disease within those 2 weeks, then that means you are safe, then you can. There are 2 methods of quarantine. There's the self, where you will be required to quarantine yourself in your home or in a hotel of your choice. But we are also considering quarantine, especially where we are getting overwhelming numbers from some countries. I mean, it's not a separate, it's not private, I can mention it freely. Like 3 days ago, we received 85 Chinese who just arrived at Entebbe airport, and we are supposed to quarantine them, but we realized that self-quarantine for such numbers is a bit difficult because they scatter across the country, and then yet our teams are supposed to monitor them every day for 2 weeks. So when they scatter across the country, sometimes they become a problem for us. So we are now calling all of them back to Kampala to put them in institutional quarantine. And these, as I told you, are issues which a minister can decide to do to prevent the people of Uganda. And that's a decision she can make without asking for any favor from anybody. Finally, as a Minister of Health, we also need to inform you that we are also battling, as we battle with prevention of the disease, we are also battling from a lot of rumors. There's a big challenge of rumors, and as stakeholders, we want to encourage you to support us to address these rumors. One of the rumors is that blacks do not get the disease. That's a rumor. We have so far about 12 African countries which are affected, and in those countries, there are also blacks affected. There are rumors that vitamin C helps. Of course, it's just a supportive, but it is no treatment. Herbs, we are getting rumors of herbs that we are treating. We are getting rumors of, the case of Mayuge, where some people were administering a local herb as a vaccine. Of course, that's criminal. And there are too many rumors in the social media. They also, what's in the situation? And of course, as you know, there's so far no vaccine yet. There's no vaccine, and there's no approved therapeutic, so far, therapeutic treatment for this condition. Finally, I heard you talking about masks. As I came in, as I putting on masks. Or those who are treating sick people putting on masks. And the masks should be the appropriate masks, the N95, not surgical masks. So if you have to use a mask, please use a correct mask, not a mask. In conclusion, this condition is still new. There are still very many unknowns, and we are all still learning. WHO and CDC, they keep guiding us on what to do and how to move. So we'll continue to work very closely with these partners and work very closely with you, our other stakeholders, to make sure that we keep our country safe. We shall continue to collaborate and learn from each other, and we are really open, especially to learn from the academia on the best ways if we manage to prevent this disease from reaching the country. Because we know once it gets here, the story will be a bit different for us. Madam Chair, I think this is what I was asked to deliver, and I hope I have delivered it appropriately. Thank you very much.
Thank you very much, Dr. Mwebesa, who is representing the Minister of Health. We are now moving to a presentation that will be delivered by Dr. Jonas Wadamariam, who is the WHO country representative to Uganda. He's going to give us some updates on the COVID-19 and the Dr. Jonas.
Good afternoon. First of all, thank you for inviting me to say a few words, and I hope all protocols observed. What I'll try to, the material on the slides is too much. I'll try to highlight a few from each one of them so that we can have an understanding for this disease, which, as you know, the worldwide, first of all, why do we call it corona virus? The reason is the virus has a protrusions which at the top looks like a crown. That's why this bunch of viruses are known as coronaviruses because it looks like a crown. Coming to this outbreak, as you know, on the 31st of December, China notified WHO that it has started observing unusual respiratory disease, a cluster of respiratory disease. This capacity of Chinese detection came from their lessons from the SARS outbreak, which was actually a lot of lives and had an economical damage. And this was reported among, the first case was around an animal market, seafood and animal market, the new coronavirus, and they were able to sequence it in a short time to make the genetical sequencing available for the world. 21st of January, WHO confirmed from the epidemiological data there was a human-to-human transmission and declared it as a public health event of international concern on 30th January. On 11th of March, as you have heard, 2 days back, in our lifetime, or after almost 100 years, we are facing with a pandemic next. Basically, it's coronas are primary diseases or harbored by in animals, but sometimes they infect people like SARS or MERS, and this coronavirus is new, and it infects, although we may not see all the cases, about 80% of the cases are mild, and definitely we have proven that it passes from human to human. It affects all ages, but it's most severe in old age. Maybe I should give you my code. You have to look. Okay. So the disease is transmitted through droplet or close contacts, and it usually has symptoms like fever, sore throat, cough, and fatigue, and so forth. So it basically presents itself like any common cold or flu-like symptoms. It has certain similarities with influenza. And apparently, in the tropics, at least in most of Africa, we are lucky that we don't have seasonal influenza. Seasonal influenza could be very severe, and this one has similarities to the seasonal influenza because it causes from mild disease to severe, even deaths, as you might have heard. The US has recorded over 13,000 cases this year of influenza cases, I think, and it is a severe disease. But what makes this one, what is the other similarity is the way it's spread, close contacts and droplets. And preventive measures are similar to influenza, but there are differences in the in its incubation period, in its serial intervals, as well as in the way it behaves. This one is not as transmissible maybe as influenza, but it tends to be more causing more disease, and we are looking at another difference is in the age it affects. If you look into in the 1980s, that affected mostly children, people who are productive. The age groups was the most affected, who died. In this case, it tends to influence, or it tends to kill more in the older age. And looking into the reported cases versus deaths, seasonal influenza causes between 3 to 5 million cases, with a death, for example, Spanish flu in millions, but 290 to 650,000 people die, with a case fatality of 0.1%. When you look into SARS, the 17 years ago, it had 8,000 cases with 700 deaths, while MERS has over 2,000 cases with 856 deaths. But Corona, in the shortest 8 weeks, had, at the time this slide was prepared, over 75,000 cases with almost 2,009 deaths. So it tends to kill more, it tends to transmit more. And it's spreading globally. Honestly, by the time this slide was prepared, we had 125,000 cases. But the live stream I am looking now shows me that we have already reached 132,000 with 123 countries affected. So it tends to spread globally faster. And this is also true that we may not be able to truly know the extent of it, because we are seeing the milder and the severe cases. And it also depends how fast we detect it, depends on the surveillance system we have and the capacity we build in the countries. So the other fact is that, as you all know, it started in China. And that first bell curve you see is when the disease was in China. And the fact that China had a lockdown made probably that bell to be shorter. The other red one you see is the increase we are seeing in the rest of the world. So now it has moved, literally the epicenter, from China to Europe. And we don't know where it will move tomorrow. So, furthermore, let me go here also. When we look into the symptoms in the Chinese study, they have seen that cough was the most prominent symptom, followed by fever and fatigue. So dry cough or wet cough, let me call it, were the common case. But the studies since then in a larger population is showing that fever is probably the most common presentation of coronavirus. And this can appear in the first 2 or 3 days. But what is more important is that in corona, we have observed that the person could shed the virus or could be transmittable even before symptoms are presented. And here we look at, while we see about 81% of cases to be mild, about 15% might go into severe cases, and about 5% get critical, and death rates vary. If you look into early detection, which South Korea is doing, the fatality rate is below 1%. It's about 0.7%. But in the general, in Wuhan, it has been looked into about 2%, and the rest of the country between 1% and 2%. So basically, we are looking into a varied fatality because of the denominator of detection. Generally, the case fatality stands about 2%. And if we look into the age distribution, that is very interesting, because if you look into the age distribution, the children are not that much affected. We start seeing a higher mortality rate as the age progresses. Here you can see, for example, the fatalities within the age of 30 to 39 is about, case fatality rate is about 0.2%. It is almost the same for 40 to 49, but it jumps to 0.6% the moment it reaches 50. By the time it's 60, it's about 1.1%, and above 70 is 3.1%, and it climbs to 3.7% for people above 80. So if you look into the natural history of the disease, as I said, about 80% present as mild, 15% as severe, and 5% are as critical. And approximately 10 to 15% of the mild cases might go into severe. And approximately 15 to 20% of severe cases go into a critical case where there will be a need for intensive care to make the survival rate better. And approximately 75% of asymptomatic cases could also progress into a milder case. But what is interesting, as I said, is that children and young adults tend to have a milder symptoms and tends to survive the disease. If we look into the virology of it, while in SARS, the peak of shedding of viruses was at 5 days. For corona, it's between 24 and 48 hours. Even prior to the disease, you can see shedding of the viruses. And the peak is that it makes it possible that people could still shed between 7 to 12 days, making them infective. So that is why we wanted to look into the 14 days as a potential quarantine days. What can countries do? When there is no case, you get prepared. And the preparation should look into every aspect of it. When there are sporadic cases, we have to focus on stopping transmission, and when we started looking into clusters, containing them will be our strategy. And if you look into the strategy, and the Ministry of Health people will explain to us that the strategy for and the plan for Uganda is looking into now trying to prevent it, but also getting prepared to detect it and contain it. The priority areas are, I think we will look into it. I have reflected from emergency response to risk communication, case finding, surveillance. All these areas has to be strengthened if we have to deal with this pandemic. Treatment, there is no treatment for corona. Whether you take 10 liters of alcohol, whether you eat garlic or take a shower 10 times, that will not cure you. What would be most important is that you take your health to on your own. How prepared the government is should not be the question. How prepared are you to prevent the disease from catching you? Which means, how frequently do I wash my hands? How frequently I make sure that I do not get into close contact? How frequently do I try not to touch my hands? And don't be surprised before this I finish if I touch my hands, because it's a very hard habit to get rid of. But for those who have received supportive treatment, they get better. And we already can see over 60,000, actually close to 80,000 people now have recovered from it because they get support treatment and the virus passes its time. There is no licensed vaccine or treatment in coronavirus. The fact is that it will affect any age, any color, any race. The only reason probably that we did not see a lot of cases in Africa is either we are not detecting them, but also the pattern of international travel and spread shows that we don't have much travel. So that might be the only blessing in disguise of not having good communication. But the fact is that now we are seeing a lot of cases in a lot of countries, and that we have to be ready to deal with it. People with pre-existing diseases are more vulnerable. People with hypertension, diabetes, and other diseases tend to suffer more, and proportionally they die more. And as I said, as the age goes higher, people tend to die more from coronavirus. And our key advice is, please wash hands and keep them away from your face. The transmission ways are mucosal membranes, the eye, the nose, the mouth. And those, if we keep our hands far away from this, we might not have that disease, even if we had an incidence of touching close to it. And the other is, make sure that we keep coughing and sneezing etiquette. This is not aerosol. This is droplets. So when we sneeze, it goes to another person or another surface. Let's keep the surfaces clean, and let's make sure that we do not transmit it to others by shaking hands. Let's try our best to show our love by saying hello in a distance. If you really like me or if you really love me, stay back and say bye to me. Hugging me will make me vulnerable. I'm happy. Okay, basically, protect others from getting sick. That means don't sneeze on others, stay away from people, and throw away the possible infected material in a safe place. Wash your hands and don't spit, and keep the people who are like Atik informed when you don't feel well. Seek medical care, not only for your sake, but you will protect your loved ones as well. And avoid unprotected close contacts, and don't don't visit or try to be very cautious when you visit live animal markets and cook the food. Stigmatize, let's say the Chinese. They may not be the center of the transmission today because the epicenter has moved elsewhere. If we believe that a certain professionals are the transmitters, then we make things difficult. And by doing that, we create fear. And when we create fear, the diseases like communicable disease are out there free to kill and to make people sick. Here, I don't know how visible it is. Some epidemiologists tries to map how the transmission is. Yes, initially it was China where it started, but since then it has spread to 123 countries. And from some of those countries spread to a second country and a third country. So our profiling from saying from this country people come and they should be stigmatized doesn't work. What the ministry did in classifying the highest 16 is to minimize the risk and to see that those people do not transmit it because it's not their nationality, it's where they come from which is causing the disease. And I borrowed this from Atek and his team. If you look at the currently of the people who have been isolated, you can see how they are distributed. Even in Kampala, they are distributed in all the districts or the sub-counties. In Africa, we have looked into 13 priority countries, and Uganda is one of the green ones, where we believe that we should get better prepared and have a higher capacity than the rest. But it doesn't mean that we are spared anywhere. And to mention a bit on Africa, today I could report to you that we have from 12 countries, and Algeria, which had five new cases, reaching 25 total case. We have South Africa, which had 4 new cases, reaching 17 cases. Senegal, which has 5 new cases in the last 24 hours, reaching 10 cases. Cameroon, Nigeria, and Burkina Faso, who had 2 cases. And in the case of Burkina Faso, the minister said it well. She says that the 2 cases are as black as I am. They just happen to travel from somewhere bringing the disease. So be sure it affects black people, and we have to protect that. And we have in DRC 2 cases, because in the last 24 hours we had 1 more reports. Cote d'Ivoire had 1 case, Ghana reported 2 cases, Gabon reported 1 case, Kenya reported 1 case. So in the last 24 hours, Africa had 19 new cases, making it 66 total cases. So the disease is coming, but we can only prevent it if you are ready for it. Not the ministry, not WHO. If you are ready to change your behavior, if you are ready to keep educating yourself and protecting your loved ones. Thank you. And make sure you get the alcohol on it.
Very nice. The mic is disinfected. So we are saying thank you very much, Dr. Yanas, for giving us the global picture of Corona. Please do take down your comments and questions as we go along. We'll have an opportunity to respond to them. And even if we eventually have too many of them, we will have to compile them and get answers to them, because this is a great opportunity for us to get the answers to the issues that we might have, so that we can contribute to prevention of corona. We have a representative from the airport, Mr. Kenneth Bainomugisha, who is representing Engineer Soma. He is the station manager for National Aviation Services. Mr. Bainomugisha, please do come and join us. I'm sure we'll have questions about the airport and what's happening. You're very welcome. We also have the incident manager now, Mr. Tek Kagirita from the Ministry of Health, who has joined us. So we are moving on to hear again from Dr. Mwebesa. I believe he has some more comments for us in terms of how prepared the ministry is, the country is, to detect and prevent COVID-19. You're very welcome, Dr. Mwebesa. He is the Director General of the Ministry of Health. I need to disinfect this.
I wish what we are doing here is what we actually do every day. Thank you very much, Madam Moderator. The good thing is that the country representative for WHO has summarized. So how do we do it? Somebody will be moving from me. This is what they call user training. So I've just gone through user training. So I'll be really literally going through what we have done as a country. Because now we are in the preparedness phase. When we are responding to these epidemics, we have what we call the preparedness phase, when we are preparing ourselves for addressing the outbreak. Then if you get the outbreak, you go into the response phase. So for now, we are already in the preparedness phase. And sometimes you remain in the preparedness phase without getting to the response phase. And we are praying that we remain in that. But getting the case late last evening. So this information has already been given. I don't think I need to go through it much again, considering that we've had a number that coronaviruses are zoonotic. The cases we got, especially the severe at the SARS, many of you will remember it, 209 H1N1 influenza, it's also a coronavirus. But I need to remind you about that H1N1 and 209. There's a very important history about that with Uganda. We had a business forum where we had very, very important delegates in Munyonyo, and one of the very, very high profile delegates developed that influenza virus in this country at the level of a prime minister of a country I will not mention, and we started scampering around because that was really a very, very high profile person. So we pray that we don't get into similar situations. That's why, as a ministry, we have even recommended suspension of some of the important meetings which are coming. At least if the situation continues as it is, most of the important meetings have been suspended. So the Middle East virus has also been talked about, now the 2019. This one also, this background has been really given by the country representative, including these countries. Actually now there are 12, Egypt, Algeria, South Africa, Nigeria. And I think these figures have changed a bit. The country representative, I think, gave us the more up-to-date by today. Our strategy for all outbreaks and serious epidemics is normally to prevent, detect, and respond. We try our best to prevent the diseases from coming into our country. Then we detect, and if the event that we detect that we have a case, we respond to it. That is the strategy of the Ministry of Health. The situation, as of now, this has been said many times, especially by my minister, that we have no case of coronavirus, at least as of now. We don't have any case of coronavirus in this country. But we have had alerts about over 1,600. That was by yesterday. I'm sure by today, it's like higher. We have had over 1,600 high-risk travelers who were screened because some of them presented with some mild symptoms, some. No, those are the ones whom we screened for isolation, for quarantine. And included over 1,000 Chinese, 244 Ugandans. I want also to emphasize here that the point is we are not targeting nationalities. We are targeting people coming from certain countries. So even if you are Ugandan but coming from China, we shall also isolate you, and we are doing so. So 244 Ugandans, 43 Italians. As you have heard, also the situation in Italy is very bad. So really Italy is on a very, very high radar for us. South Korea and 240 other nationals. 606 have completed 14 days of quarantine, and there are still others who are still under follow-up. We specifically tested 26 persons since 29th January, but I think that doesn't include numbers which were tested today, because today we picked some cases which were isolated, and we took samples for testing at Uganda Virus Research Institute. And as I have said it already, one of the preparedness or activities that we are doing is that we have the capacity to test all suspect cases in this country and adequate facilities to do so, and in real time. What further have we done? As a country or as a ministry, we have what we call the National Task Force. This National Task Force has been going on for over a year for Ebola. So when this issue came up, we reactivated this National Task Force with its relevant subcommittees. This National Task Force has subcommittees for, as I told you, surveillance. We have dedicated epidemiologists who do surveillance, and they can follow up each case as may be identified. Then we have like risk communication, those who are responsible for advising and media communication and everybody. Then we have case management, we have teams for laboratory, we have teams for logistics and prepositioning of all the required materials. We have psychosocial support, because some situations, like if you are going to quarantine people for 2 weeks, you need psychosocial counseling, so we have dedicated teams for that. As I already told you, we have established treatment centers in Nakuru. Nakuru has 10 beds, in Tebe, which has about 25, 26 beds, and Mulago is to address the huge cases that they get, even that we get many numbers beyond, let's say, 20. But also if we get severe, those presenting with severe manifestation which require ICU and dialysis or oxygen. We've been doing weekly briefing, press briefings, and travel advisory. We've issued guidelines on transmission, to prevent transmission, and mass gatherings. We shall be circulating those guidelines for mass gatherings. We also have guidelines for self-isolation. What does it mean? Of course, we didn't come with some copies here. It would have been appropriate if we had come. But we have guidelines which tell you if you are doing isolation, self-isolation, what are you supposed to do? What are the do's and the don'ts for self-isolation? We have prepositioned stocks of logistics, especially at the treatment centers, but also at points of entry and regional referral hospitals. We do daily situation reports in the country preparedness, and we are also partnering with the Civil Aviation Authority and the security at the airport. Let me talk a bit about screening at the airport. Every airline which comes in at the airport now, everybody is screened. We have screening at the general arrivals, we have screening at the VIP up, and we have screening at the VVIP. You know the VVIP where the presidents arrive, which is not part of the main terminal, which is near the UN building. We even have screening there. So even if it is a president who comes, is screened there. Of course, we work with the security to make sure that everybody is screened. I know yesterday somebody claimed he was in Parliament and claimed he was not screened. And I want to thank the Speaker of Parliament who appropriately advised him to guarantee our girls that whoever comes, whether you are an MP or a minister, you must be screened. There's no point of saying that you are a very big person, you screen. Now, at this juncture, maybe I can introduce our incident commander. Actually, we called him incident manager. We started calling him incident manager, but we later changed to incident commander. That man has a lot of powers that he can even detain a minister, and he can even detain me when he chooses. That's why we called him commander. Because some of his actions actually require command and control. It is not just decisions, but he requires to take some decisions. Because with epidemics, especially such killer diseases, sometimes the decisions are not negotiable. Somebody must make a decision, and the decision must be followed by the person who has been asked to follow that decision. So, this big man here, Atek, you can stand up, is the incident commander for coronavirus. Alan is a commissioner for epidemiology surveillance. He's the incident commander for Ebola, but we didn't want him to do both. So he's still, because while Ebola is going down, but we are still really monitoring. So he's still responsible for Ebola, and he's the incident commander for Ebola. So, apart from Entebbe, we have also intensified screening at other border points of entry. At Busia, we have also intensified screening. We have deployed their teams of epidemiologists and staff who screen all those people who come. At Malaba, and at Chanika in Soro, and in Elegu, that is north when you are coming from Southern Sudan. So all those people have been trained, they do the screening, and they are mandated to direct that you be screened. When we pass the advisory, we have been advised that some people are now coming by Kenya Airways. They get out in Nairobi, and then they come by road and try to enter the country through Busia and Malaba. We've got that information, and we have promptly alerted our teams that if you come, our team must know, because you may claim you are coming from Nairobi, but our team has the capacity to check your passport to see when did you even arrive in Nairobi. If you arrived in Nairobi 2 weeks ago, well, we are okay with you. Of course, now Nairobi is getting cases also, but 1 or 2 cases is not at least on the high radar for us. If you arrived in Nairobi 2 weeks ago, that's comfortable for us. But if you came, let's say from China, you arrived in Nairobi and you were there 3 days, and now you are trying to enter through Malaba, you'll still be quarantined like as if you came through it. So that's what we have advised our teams, so that people do not have a weekly briefing by the minister, by the state commander, and this is the training of some of the screeners, and which just being shown. We also carry out, and we advise the country accordingly. We use 3 criteria for categorizing the countries. The first is the total number of cases, the cumulative number of cases per country. The higher the number of cumulative cases, the higher the chances of getting a case from that country. But we are also, like the WR was saying, we look at In the last 24 hours, how many cases did you get? We also consider that when we are categorizing the country. But we also see in the last 7 days what was the situation in that country. And that also helps us to categorize these countries. So as I had promised you, what this has been going on around, this was the last one we released on Wednesday this week. This is the category of the countries. The first category where when you arrive here, you must be quarantined, are those 16. And they include Italy. As I told you, Italy is doing badly. San Marino, Iran, South Korea, France, China. Of course, we get very many people from China. Germany, Spain, Belgium, USA. Initially, we started with 5 countries. We actually had, we started with China. We started with China, we had South Korea, we had Japan, but Japan has dropped off that list. We had Iran, and I think we had also added more countries because we realized the countries reporting many cases were increasing. So on top of the 5, after dropping Japan, because Japan the situation improved, we maintained the other 5 and added on another 10. I think now those are 16. So all those people arriving from those countries will be subjected 14 days in isolation. And as I told you earlier, it can be self-isolation, but we can also direct institutional isolation, in which case we shall put you in a designated place for isolation. But as of now, apart from the team of Chinese I told you about, we have been doing self-isolation. And when we isolate those people, we have epidemiologists who follow up those cases regularly, either by phone call and those in Kampala by visiting. But even those in districts, we have district focal persons. So if you say you went to Kapchorwa, we alert the team in Kapchorwa, the DHO, and the district focal person that there is Mwevesa, he arrived from Belgium this week and he is isolating in Kapchorwa. Your team must follow up him every day. And we expect the DHO to give us a brief every day on the status of that person being isolated. Then we have category 2, travelers from those 4 countries are really being observed very closely, but as of now, we don't isolate those countries. Then category 3 are travelers from any other countries, and we do not, as of now, we do not have any problem with travelers from those countries. Just again to remind you that even if it is, even if you are Ugandan arriving from these countries, you will still be isolated. What else have we done? We have oriented our national response team, rapid response team, and trained them and given them all tips about the disease and how to follow it up. Then we have formulated those rapid response teams to follow up cases in the districts. But also you realize that we are doing one of the things which will help us address or prevent this problem is to make sure that everybody is given information about the disease. And here I want to thank the mass media, the media houses, the print, and the electronic media. They have done a very good job to educate everybody about this condition and about the disease. Actually, it was a directive from the president, and it was a directive from the Uganda Communications Commission after receiving an official letter from the Minister for, is it called ICT and Information? It is a directive that all media houses must give information about coronavirus every day and during prime time. Because what they were doing, they would give information, they would give us even opportunity to go and talk about the disease, but during funny hours, early in the morning, around lunchtime, when people are at work, in the morning when people are rushing to take children to school. But now it's a directive that this information must be given and free during prime time. That's why you have been seeing on TV, NBS, BBC, very, very clear information, guidelines coming up in the middle of the news. Then we have enhanced surveillance at points of entry, as I've talked about, those 5 points of entry, Eleku, Busia, Malaba, Chanika, and at the airport. We have developed guidelines for mass gatherings. We have not banned mass gatherings, but what we advise is that you follow the guidelines that we have given, and these are very well printed. We shall be printing and circulating them. People have been contacting us, we have been giving them copies of mass gathering. But in summary, it's mainly to have a controlled way of entering. You take temperature screening, you do hand washing, and then you educate the people about the gathering. And then people who test, who have temperature, who are sneezing, must be advised to keep away, including even the churches. Because we have even been telling the churches, as I told you, people who are sick should be advised not to come even to church or to the mosques. And it is really in the interest of themselves and even of the rest of the congregation that we do not come to church or mosque when we are sick. And we have even given the mosques and even more information and guidelines about how to protect their congregation, including this sort of business we used to have of wish each other peace, the shaking of hands in church. We have advised the churches we can wish each other peace by waving hands, and including for the communion, the pastors and the reverends must disinfect themselves before they do for the communion, for the offerable communion. If some of you saw what happened when during the commemoration, enthronement of the Archbishop, we did screening right from the gate. We had to disinfect and take temperature right from the gate. We had to do it again in the middle of the gardens. We had to do it again as they entered church, and before Holy Communion, we had to do it again. So people did it on average about four times per person during that service. All that was to protect the population. And you recall, even during that meeting, we had very many foreign delegations or delegates who came for that action. I think, of course, we have to activate the districts also and to train them in order to respond. And the regional referral hospitals to be prepared for this. Aggressive sensitization, I've talked about it. And also mobilizing resources, conduct community-based disease surveillance, support surveillance, partnerships in the country. As I've already told you, we have prepared guidelines on to do what should be done and what should not be done. This has been circulating everywhere, emphasizing washing hands, covering your nose and mouth with a handkerchief or a tissue. If it is a tissue, you dispose it immediately. If it is a handkerchief, it must be washed every day and ironed, especially like doorknobs, handles, furniture, and the bedside tables, cleaning and disinfecting bathrooms. I think the WR talked about this. Staying at home for those who are sick. And if you develop symptoms, please inform our team, and we have those guidelines. Those called down. Those who are in quarantine, if they develop symptoms, run to an health facility. Because we always say, if you develop signs and symptoms, go to the nearest health center. This time it is a bit different. If you develop signs and symptoms and you are under quarantine, you just call the numbers that we gave, because there you require special support. In that case, we shall send our dedicated team, which will evacuate you and take you to designated places. Because we don't want you to go to our health center, because that health center may not have the capacity to manage you. Actually, you may just increase risk to that health center and to yourself. And that one is a bad slide, certainly. But it highlights what not to do. Among those is, of course, not shaking hands, staying at home when you are sick, and not sharing certain items like toothbrushes and dishes. It also highlights issues of not using masks unless you are sick or unless you are taking care of the one who is sick. And Don't take self-medication. Do not spit anyhow. You spit in a toilet or in a dedicated sink. And avoid travel when you have symptoms. We are advising, if you have symptoms, do not go, do not travel, do not go to churches, and do not go to any other mass gatherings. And again, just to emphasize, it's really a policy of government that now we suspend travel to those countries which are affected. We have sent this message to all ministries, all districts, even CASITA, the business people, and even the Manufacturers Association. Those countries we advise you can postpone as we monitor the situation, do not travel there. But I also want to emphasize that what we have also noticed, that the Ugandans who are coming back and are quarantined are not very well behaved. Actually, what is interesting, the Chinese, the people who think that the Chinese are a problem, the Chinese have been the most well-behaved groups we have had. Most of those who have been asked to be quarantined, they have quarantined and they are following the guidelines. Actually, foreigners are doing it very religiously. But the Ugandans, we tell them to quarantine, the next morning they're in the Chikubu, they are in their shops. So for those Ugandans, we are going to invoke certain laws and we shall eventually use more harsher means of quarantining them, because we are thought this is a mechanism of understanding. You understand the risks you are posing to yourself and even to your own family. So we advise that you follow the procedures of quarantine. But where we find, because we have ways of tracking, where we find that we advise you to quarantine, and tomorrow we find you at the dark spa in Chikugo, then the next will be enforced quarantine. And when we put you in our enforced quarantine, it will be institutional, but at your own cost. Ladies and gentlemen, I think those are some of the measures. My colleagues will add on what I may have forgotten and left. Thank you.
With us, what the Ministry of Health is doing. Thank you, our colleagues who are following us online. We've received your questions. Keep them coming. We are going to share the questions and we'll get answers to the questions that you've posted. We are now going to hear from Dr. Lisa Nelson. She's the Country Director for CDC. And CDC has been providing a lot of support for about 5 minutes. We are now getting shorter in presentations so that we can spare time to talk with you. Thank you.
Good afternoon. I have a few slides, but I promise to be brief. Professor Wanyeza, from the School of Public Health, Ministry of Health, colleagues, WHO, academic partners, and others. If we could just go back to the first slide, which was the title slide, or I can maybe try to do that. Let me see if I can do that. Yes. So good afternoon, and I did just want to report, this is, as we've heard, a worldwide phenomenon. In the United States, as of the latest data, we had 1,255 confirmed cases and presumed cases, 35 deaths in 44 states. We can go to the next. I've got that here. And just to say as I begin, CDC has been working in Uganda since 1991. We're part of many global initiatives that I'm sure you're familiar with, such as PEPFAR for HIV, PMI for malaria, the Global Health Security Agenda, and others. And we're really proud that we fund almost exclusively Ugandan partners. So you can see government partners there, Ministry of Health, that includes the Emergency Operations Center, Uganda Virus Research Institute, Central Public Health Lab, as well as Ugandan institutions such as IDI, such as AFINET, and others. And these have been great partnerships. When we think about the work CDC does around the world, we're part of the Ministry of Health of the United States. So many of my colleagues in the United States are at airports screening travelers, are providing support to our Department of Health and Human Services, and even the White House, are working with state and local health departments. But we try to divide our work into a number of core areas that you see here, and I'm going to talk through some of the examples. Work that we support in laboratory systems, in public health surveillance, in workforce development, emergency operations, real-time evaluation and research, and at the bottom, public health programs and service delivery. So here in Uganda, we really began our work in global health security in 2000 with a demonstration project. Uganda and Vietnam were two countries worldwide that were selected for this effort. And you can see that it involved looking at laboratory networks, real-time information systems, including support of results returned through SMS messaging, and support to the inauguration and ongoing development of the Emergency Operation Center. So just one example from lab, and this is a busy slide, but really this has involved strengthening all the way down to the community, understanding alerts, collecting appropriate specimens, using all means of transport, BOTA drivers, POSTA buses, et cetera, to get samples to appropriate facilities for testing and getting results back to clinicians and patients. And this model has been really successful. We've used it for many disease outbreaks, including Ebola. This graph, the tall red bars show the number of cases of Ebola outbreaks and other viral hemorrhagic fevers. The bars, which you can barely see below the line, are the number of days. And Dr. Mwebeza talked about this, and others have talked about this, that one of the real success stories in Uganda has been reducing time it takes to diagnosis through being able to do the testing at UVRI and where appropriate at point of care. So we can now diagnose Ebola once that specimen gets to UVRI in under 6 hours. And CDC, along with other partners, has provided substantial support. The other thing you see, though, along the x-axis is we're detecting many more smaller outbreaks, but the good news is none of them get to the levels that we once saw in the early 2000s. It's great to see Dr. Makumbi here. This is an old slide because I think it says 30 times that the National Task Force has met, and I think the National Task Force has probably met 30 times in the last month. But I think it really has served as a model. Many countries have come to visit Uganda's Emergency Operations Center, and we certainly have used the infrastructure for Ebola and now for coronavirus or COVID-19. One of the other things CDC supports is the Public Health Fellowship Program. This is a postgraduate program together with Ministry of Health, with AFINET, with WHO, and with the School of Public Health to train 12 fellows a year. And you can see on this map all of the outbreaks, more than 100 that they've assisted with since the program was restarted or expanded in 2015. And right now we have fellows who are supporting the hard work of Ministry of Health and colleagues at the airport to do screening, documentation and contact tracing, as well as support to efforts to follow up people in self-isolation and any contacts should we have them of cases. One issue I'd also like to highlight that we've been working on quite intensively with Ebola is infection prevention and control. This is critical with a disease that is airborne. And I think it's really important as we go forward that we think about how we strengthen health facilities, particularly high volume health facilities where patients or suspect cases may turn up to protect other persons in the hospital, but also very importantly, to protect health workers. And finally, this is my last slide. I think we've really used our long-standing investments in laboratory, in public health surveillance, in workforce, emergency operations, evaluation and research, and public health programs to quickly pivot to support Uganda on coronavirus or COVID-19. And these are just some examples. We continue to support lab through UVRI and UNHLS. We continue to support the surveillance efforts led by the National Task Force and the EOC. We continue to support with the Public Health Fellowship Program. And I think we're even looking at helping to bring in some additional staff. There's a lot of work to be done, and also redeploying some of our CDC colleagues to help support preparedness and response. I think finally I would just highlight that again, Uganda, as Dr. Mwebeza said, has a lot of experience in identifying and responding to disease threats. But I also think it's critical, as others have said on the panel, that we all do our part. This isn't just responsibility of Ministry of Health, it's responsibility of all of us. And I can also share that right now we have several members of the U.S. Embassy in self-quarantine. Unfortunately, they all traveled to Germany and they came back after the list had been changed. But we understand the need for this, and I think we're happy to comply. Thank you.
Thank you very much, Dr. Lisa Nelson, for the support to many institutions. We are proud to be associated with the Public Health Fellowship Program, trains so many people, including our very own Kenneth, who is the manager for the National Aviation Services. He's actually a fellow from the Public Health Fellowship Program. So it's a good program that's added lots of value. We are now going to hear again in under 5 minutes from Dr. Simon Antara. He's the Executive Director for the Africa Field Epidemiology Network, also supporting the same cause.
Mine is not a PowerPoint presentation. The chairperson, the Director General, also representing the Minister, the Commissioner of Health, WR, the Director of CDC, fellow panelists, everyone present here, good afternoon. First, I want to thank the organizers for inviting me to be part of this important dialogue. Epidemics, and more so pandemics, come with serious health, economic, and social consequences to communities, nations at large. The response, therefore, should be appropriate, effective, and comprehensive enough to mitigate the challenges occasioned by these events at the community, national, and global level. A dialogue such as this is a key element in the preparedness and response itinerary. Now, AFINE's work supports the development of field epidemiology capacity in sub-Saharan Africa. This is a capacity that is so much needed to respond to a wide range of public health issues, including public health emergency response. And so for the past many years, AFINET has been working with Ministries of Health, Ministries of Agriculture, including those of Uganda, schools of public health, of course, including that of Uganda, and our main funder, the US CDC, to develop capacity in field epidemiology in the sub-region. So the work we have been doing all along prepares countries, prepares ministries of health, supports them to respond to public health emergencies. And I believe that includes COVID-19. In 2018, recognizing that many countries do not have the recommended number of field epidemiologists as recommended by the Global Health Security Agenda, AFINET launched the AFINET Corps of Disease Detective. This is a body comprising alumni of various field epidemiology training programs who would be quickly mobilized and deployed even across boundaries whenever there is need. Now, specifically for COVID-19, I want to say that AFINET has been part of the National Task Force. We've been part of the discussions and we've been part of the planning. With funding from and the program to follow up high-risk travelers. With funding from the Bill and Melinda Gates Foundation to AFINET and to Africa CDC, AFINET has been collaborating with the Africa to build capacity in various areas across the continent to respond to this emergency. The training we have organized in collaboration with Africa CDC includes event-based surveillance, one that was organized just a week ago here in Cameroon. CDC capacities risk communication, and of course, at the emergency ministerial meeting that was held 3 weeks ago in Addis to advocate for support to preparation and the response to COVID-19. Certainly, in situations like this, I believe that governments, partners, civil society, and the community at large have a critical role to play. And AFINET is committed to continue to support in whatever way it can. Thank you very much.
Okay, thank you very much, Dr. Antara. We're going to hear from Kenneth Bainomukisha, who is the Assistant Manager for the National Aviation Services. I'll give you this, Kenneth, so you probably don't have to.
Thank you so much, Professor. Good morning, dear participants. Good afternoon, sorry. Sorry. From the airport, definitely I would like to appreciate all partners, especially the Ministry of Health, who have intensified all efforts to support the screening and surveillance system at the Entebbe International Airport. I must state that this virus or this disease would not be spread the way it has spread if it was not for aviation. So we are where we are because of aviation, and all efforts, in fact, around the world are trying to mitigate what can be imported in their different countries to ensure that the disease can actually be stopped wherever it is without being imported in their countries. Now at the Entebbe Airport, some of the activities really that have taken place or that are taking place is a strengthening of the already existing point of entry public health officers or the board health officers who have been beefed up by the Ministry of Health with support from partners to ensure that all passengers that are entering the International Airport undergo a proper screening. All passengers are screened except that the high risk are the ones that has been explained that are advised to undergo self-isolation and quarantine for the period that has been prescribed already. Now, we must say a lot, of course, continues to be done at the airport. The Uganda Civil Aviation Authority coordinates with the airlines that are coming into the International Airport with all the advisories that are released by the Ministry of Health, reaching all these airlines in real good time. Passengers prior to arrival are expected to fill their forms inside the aircraft and should present them on arrival. Now, there is no exception because for all passengers and crew, all go through the same process of screening. And we must state that this has actually been quite helpful in trying to, looking at why we are still a bit safe, and in case really there is something that is supposed to happen, we shall definitely watch it. Now, in terms of aviation, once again, there are airspaces, and with these travel restrictions, we see some passenger numbers actually dwindling, including the cargo that is coming into the country. Fortunately for Uganda, we have not yet had complete suspension of any airlines that are coming into Entebbe International Airport, except for some airlines who have actually announced reduction in their frequencies. Emirates, for example, has announced reduction of frequency by 14 flights up to the end of April, and Qatar Airways also reduced by 1 flight beginning 1st May. Other countries are actually a bit worse. A country like Kuwait, the Kuwait International Airport has been closed. So it is as bad as that. Looking at the controls that are in place, we see numbers reducing, but significantly we have not yet really felt either as Uganda that airlines have stopped coming. but moving forward with more countries being added on the list with numbers for passengers and cargo, and therefore if they don't have passengers, we think there will be significant reduction in the number of frequencies these airlines implemented international airport. I'd like to keep it a bit short at that, and maybe still available to answer any questions that may come. I thank you so much.
Thank you. We have our last 2 minutes from Dr. Elizabeth Ekrapa from the School of Public Health. She's the chair of the Department of Health Policy Planning and Management. She wants to talk about the Public Health Fellowship Program because we had a beautiful slide from Dr. Lisa Nelson, so she will just add on whatever else in about 2 minutes. Thank you.
I'll try and use shorthand to fit into the 2 minutes. I acknowledge, representatives from WHO and Ministry of Health. I want to say that our School of Public Health, we play our key roles through the 2 FETP programs, through our alumni. I know many of you are watching the live stream. We acknowledge what you do through us even after you have left, and also through our faculty. And of course, we do this with the support of our partners, WHO, CDC, affiliate. And I want to just comment on 2 things, what we are doing and where we think we can do more. The first thing that we are doing is what we do as an academic institution. We have already emphasized the importance of sharing this information. And many institutions are doing this. My son in nursery came back home like 2 weeks ago and told me there is a new disease called coronavirus. We have to stop hugging and greeting because of this disease. So just like other academic institutions, we are doing our best to spread the word about coronavirus. We are also doing our role as employers to ensure that our employees are safe, and so we are putting in place all the sanitizers and travel restrictions, because as we have emphasized, we must work as a team to make this happen. And lastly, we are partnering with Ministry of Health and other stakeholders in the country preparedness activities. Some members from the school providing technical guidance through the National Task Force, through the college. We have a colleague who is in CDC Africa. We are also participating in country preparedness activities, several of which have already been mentioned. There are areas where we think we could do more. One of the areas is in preparing human resource to manage the epidemic. As we have all noticed, when this epidemic sweeps in, it gives you no time to prepare. So with the alumni that we have out there from the 2 programs, we think we have a set of foot soldiers who could do a lot. We could also do more in terms of contextualizing some of the evidence that we are getting, because as we are aware, the appropriateness and relevance of this evidence, differs depending on the stage of the epidemic, depending on the context of your country, depending on the context and the economic impact of some of these decisions, and also depending on the feasibility of these measures. And so we need to think through them carefully and pick up what is appropriate for us. And lastly, we think that we can do more in terms of preparing stakeholders. If you read the paper yesterday, the hotels were saying, we are being told to self-quarantine. People are being told to self-quarantine and they're coming to us. But what do we do with these people? And they posing a threat to us. And so perhaps in terms of being prepared, when you self-quarantine, you go back home, perhaps to your, family, and they are the ones at risk. And so we could do more in terms of working with all the stakeholders, some of you represented here, to ensure that we are all able to play our role. So I'll shut up right there.
Okay, thank you. Please join me to appreciate all our panelists here for the excellent presentations. Now we are open to your questions and comments. We already have 6 questions from colleagues who are watching us through the live streaming. And I will start with these as we wait to get more from those of you who are here. I can see 3 hands there. So as we prepare, the first question we have here is going to Dr. Mwevesa from colleagues who are live streaming. They had Dr. Mwevesa talk about an exemption, and they were wondering what is the criteria for exemption? Are there people who are exempted, and How does this really work? We have a question also from how exactly is this happening? Can we provide more guidance? Because it looks like we are endangering the people at home, and there's transmission happening there depending on how they behave. So can we speak more about this quarantine? What exactly do we expect people to do, and how do we track this so that we protect the family members? I'll direct that to the commander, the incident commander. We have so many questions coming in from Twitter, questions coming in from the people that are watching from YouTube. What is the minimum numbers for this gathering is the other question. Dr. Alan Muruta, what is the minimum number for the mass gatherings? I think this question is related to the one I asked the incident commander. After 14 days of self-quarantine, what happens? Do I just go and work? Do you actually check? What should people do after the 14 days of self-quarantine? Is there something you'd like them to do before they go back, or can they just walk back? Are they okay at that time? So I will stop at those for those from the coming in online. I will get back to the other questions online after giving an opportunity to colleagues who are here. Let's have hands up. I hope we do have a mic going around for the people that are here. Please do say your name and who you're directing the question to. We have Dr. Kanyesi here at the front.
Thank you, Chair. I'm Dr. Kanyesi. I'm going to ask a question and then make a proposal. The question I want to ask is simple. We have all been sanitized and we had our temperature taken. What did we do to those whose temperatures were found to be raised? And indeed, what is going to be happening? All those people who come and show that they have a temperature and they have not coming, they are coming from category 3. Now, my proposal is that I'm here in 2 categories. The first category is that I'm a Dean of the School of Medicine, Uganda Christian University. We have over 10,000 students for the whole university. My Director of Medical Services is here with 2 of my students. 2 students stand up. This is the first time you've been in a bigger, these are second-year medical students. Thank you. Now, as we talk, I can see there is a lot of activity. We say this is an easy epidemic, but when we talk about sanitization, which we are doing here, we who are here and are lucky. When we is there anything our partners to be able to go away knowing that there's going to be action? I am here in another capacity. I'm the president of the Uganda Public Health Specialists Association. We've got over 2,000 people qualified with at least a master's in public health. They have been, in fact, some of them have told me, you must take me to the minister. They are here ready to be the foot soldiers. I want to pledge that these people are available and we must make sure we use them. Lastly, we've been talking about self-quarantine, mass media, social media. Those of you who are behavior scientists, you know that behavior is actually changed basically through interpersonal communication rather than mass communication. Those things on television and papers are good, but the behavior can only be changed by person to person. This is proven, and I think that we better use of all our available resources to do this. So what I'm really proposing, Dr. Wanyenze, we have no choice. There has been a very, very powerful response, even before we see the first case, in the form of an organized project that is going to marshal forces and is going to get equipment that the doctor have asked for, so that we are on standby to be able to mitigate. Thank you.
Thank you. We'll keep the questions to 1. He had so many capacities and got away with 3. Let's keep it to 1 so that we can give a chance to several other people out there. Thank you. And keep it short.
Thank you. Dr. Tom Charles from Lira University. This is to Dr. Preparedness. It was very nice to hear that Japan dropped out of the list. What did Japan do that Uganda should also emulate in case there is a case? And finally, the preparedness in the country, especially for treatment centers, when we hear Nakuru and Entebbe, then we are talking about regional referral hospitals in case there are bad cases that need life support. How prepared are we in terms of life support up country? Thank you.
Thank you. Thank you for keeping it short. One question. Say who you would like to direct it to, or if it's open, mention that as well. We will pick it up.
Yes, my name is Olive Namadzi, and I'm the Secretary for Public Health at KCC. I'm here to represent the Lord Mayor. I want to thank you because today I've got the facts about COVID-19. I'm very happy about that. Now, I just have a few suggestions. One, you talked about screening people at the airport, but I'd like to know, do you mean this screening that has happened here? If that is all, I think we need to go an extra mile and disinfect these people that are coming in, because I have seen it. I've seen some countries doing it where they are literally spraying these people that are coming to the country. Then I also want to ask, at what point do we hope to engage the politicians in this fight? I'm seeing the minister moving around here and there, but you find that these politicians are here and they have very large masses and people listen to them. I think Uganda, we need to prevent COVID as much as we can, and we need to use every resource that we have. So I want to find out profile people, but I also want to find out at what point are we taking this gospel of COVID-19 to that ghetto? Or is it that they are susceptible to this COVID-19? At what point we hope to take them to the ghetto? Because we are bringing up talk shows, we are bringing announcements, but I've seen some in English, but I think we need also some of them in the local languages. I think it is important. Then, Ministry of Health, I think there's a lot of burden on you as a ministry, and I think you need to empower your other agencies like Kampala Capital City Authority, because I was sharing with somebody from public health in Kampala Capital City Authority, and I was asking, what are we doing? Because I'm seeing KCCA is really like not coming out so much, and they're saying, no, the ministry, it is the head, it is handling, and I feel like even us as KCCA, we need to really come out. So I think ministry, you need to empower some of these other agencies to also come out strongly to fight COVID-19. Thank you.
Okay, we need to take this to the ghetto. That's very nice. Keep it at one question so that we can have many more people. We have quite a number of questions coming there. Just one, keep it brief.
Thank you very much, Dr. Wanyeze. I'm called Dr. Gonsha Rehema from Kasita, Uganda. I'm a board member. And one of the big questions that my members in the community wanted to be highlighted on is the information going on that money could be one of the ways that COVID can be transmitted from one person to another. In mind how rapid and fast transactions are happening within our communities, this should be highlighted. Also, second-hand clothes, we've had information that there can be a way that coronavirus can be transmitted. Thank you.
Can you take some more? Should we take some more? Take some more?
Yes, please. I think we're going to keep the questions coming because it looks like we have really key stakeholders. The last one was from the business community about money spreading COVID. So I don't want to stop this, and I'll request the panelists to take this so that each of you can take a few questions and respond to at the end. We'll summarize the responses, but we'll try to get all your questions and concerns.
I want to know, would have been advise people to do self-quarantine. But actually, I want to go to ask the WHO director that is this COVID transmitted when somebody has offered clinical features, or even when he is at incubation period, he can transmit this disease. So maybe let's put us clear on that one. Thank you.
We had the same question from someone online. They actually want to know if they should be worried about asymptomatic people or only people who already have a temperature and who are sneezing or whatever else.
Thank you. My name is Gitat Geoffrey, Senior Vector Control Officer in Sobel. My question goes to the Director General of Subsidy. You employed us public service, and my mandate is to do fumigation, including sanitizing. I'm told for that, but I'm seeing everybody gambling. That's a technique. Not everybody is supposed to do that. That's my mandate. We have a problem of yellow fever now, and COVID has come in. We don't have guidelines for zoonotic diseases in Uganda. We have a draft which was supported by WHO. They sent a consultant from WHO Afro. But WHO now has to do the WR is here. We need the money to finalize. We have a KCCA used to have vector control staff. They retired, they were not replaced. We have rats all over the city. Bedbugs, cockroaches, mosquitoes. Where are you? You just need 6 million to control all these rats, cockroaches.
Summarize so that we can get, I know you're raising very key issues. We'll hear about the cockroaches and your mandates. Okay.
Thank you. I'm Abou Solomon from the Youth Hub Uganda. Youth Hub, it's an NGO. My question goes to Mr. Binomcha, Station Manager. You've told us how you talked about weekly press briefings and travel advisories and partnership with other security organizations. But sir, there are other places of concern, as you said, about, for instance, there are these people that use buses. People are not taking it as much of serious as maybe to the airport. So my question goes back to you: if you tighten the security at the airport and maybe you do the screening, and the other side of the borders, we face the same problem of people that enter without being sanitized. It's a problem. So we need to look about that. Thank you, sir.
From KCCA. So I'm representing my director at KCCA Public Health. I delayed to come because we had a meeting with the transporters, the owners of the buses in the city, and basically disseminate the information from MOH and also hear their perspectives. Their concern is as good as what we wanted. We want a lot of awareness, a lot of information, and emphasis on screening. The experience is the screening from DRC borders is very good, but the same is not happening in Busia and the other side, and Malaba. They wanted us to urge the stakeholders to emphasize on that. My question is to the incident commander. In 2014, when we had that Mabag, the Mengo Mabag, we did contact tracing, and it was very difficult to do in Kampala. The moment you have a contact here today, after 2 hours, it tells you I have reached the bus park, I am here. Within 8 hours, it tells you I'm in Bali. We need to plan for follow-up of people in Kampala in a different way. I hope you have put that into consideration. And secondly, the messaging for people that are under quarantine, self-quarantine. the messages we have so far are for people who are either suspects or who are coming from abroad. We need a special message for those people so that they're able to feel comfortable and be a bit reluctant. And finally, testing. I don't know whether the DG talked about it. Do we have the testing kits now, and how can we be able to access? Thank you very much.
Okay, we will get some responses. We have really many questions, and then we will get back and take some more questions. And I'll also request the panelists to keep the responses brief so that we can get some more questions. I have so many other questions coming in on my phone. Please do write down the questions. If we get to a point when we cannot answer all of them, we will still get them to the relevant authorities and get answers back to you. When you do, and if we don't eventually answer to it, include your email address so that we can send you the questions. We will start with Dr. Mwevesa had a lot of questions. I hope you'll keep the answers to the point so we can check with the other panelists as well to answer some of them. You can pass over some of them. You don't have to do all of them. Thank you.
Thank you very much, Madam Moderator. Actually, I'll only answer one or two, then I'll pass the rest to my colleagues. I'll answer one where I said my own body to bury. And I said I had exempted somebody. I actually said that as a joke. I didn't know that it was going to be it as a serious issue. We do not exempt anybody in this country or even abroad. With this condition, you cannot exempt anybody. So that one was said just as a joke. Just want to emphasize that anybody or everybody who falls within the category, if you are coming from the countries under question, you will be exempted. You already know very many people who are under quarantine, including some prime ministers of some countries out of this country who are under quarantine because they became contacts with some people who showed symptoms. So nobody is exempted. You can just emphasize that. Then messages, they talked about messages. We are translating all messages in the main languages. It's not only English, Luganda, Ishu, Nyakitara, Luo, and all the major languages in this country, and those messages will be saturated. On testing, we have capacity for testing, but we only test those who are showing signs. I've seen people requesting to test just because maybe they feel they want to be tested, or maybe I developed a flu. But you must fill a certain criteria because there is case definition. You must fill a certain criteria for you to be tested. So if it is a question of those who meet the case definition, we have for testing them. We've received the kits through WHO following the marine regimen for testing, and we get results within 3 hours. We can run 72 tests per test at a go, and we'll get those results in 3 hours. Then my colleagues can carry on with the rest of the questions, especially on self-quarantine, number of gatherings, after 14 days of self-quarantine, what next? I think I'll answer them. And then the WR will help me what Japan did to get out of category 1, how they managed to bring down the cases. Thank you very much, Madam Moderator. So there was this concern that why self-quarantine at home. We found that this is the only feasible option in the circumstances, because you may wish to know that currently we are following up people in their thousands. So institutional quarantine brings in the complexities of logistics and other things. And so that is the most viable option that we can follow. He highlighted that the attack rates are high, and I don't know, it could have been worse if we had the institutional quarantine, in my opinion. So even if they are high, they could have been higher with institutional quarantine. The minimum number for mass gatherings, we feel that any number above 15 is high enough for transmission to take place, and therefore need to observe the precautions. And that's what we are taking for now. And they are not very different from other countries. What do you do after self-quarantine? But let's first examine why self-quarantine. First of all, you do self-quarantine for 14 days because that is the time we consider to be the average incubation period for the coronavirus if you are infected. And so, if you complete the 14 days and you are not showing any symptoms, most likely you don't have the infection. And therefore, you will be free to stop self-quarantine. However, we have a procedure of issuing certificate at the Ministry of Health, so that if the community around you ask for if at your respective office, but also for our records, because we need to take you off the list of those that we are following up. So we give you a discharge certificate that you have completed the 14 days of self-quarantine, and now you are free to interact with the rest of the community. I will stop it at that until guided otherwise.
Okay, so we need to check, there's a question that was passed on to the WHO country representative, and then we will check in with the commander had a question, and Kenneth, and then we will get to some comments from the CDC country director and the appellate, as well as Elizabeth here.
Okay. Thank you about the question about Japan. It's not only Japan, but we can learn from the various countries what are the good practices. The good practices which made those changes possible, or for countries to decrease the number of new cases or new cases, is fast action and hand hygiene, making sure that their population takes hand hygiene and social distancing seriously, and contact tracing. I think these are the part of what is the most important to control the spread, but also ensuring that those mild and severe cases are well taken care, and the health facilities have a good infection prevention and control are also the measures which are helpful. For example, in South Korea, their emphasis on early diagnosis or detection and testing has bear a good result and less mortality. A question on whether this is a disease of the rich. No, it's not. Basically, I thought you got that. And the less areas where we have hand sanitization, where we have water, soap, and so forth, the more it will spread. The attention, they attract that to tell people that this disease does not spare anyone. About the issue of money and other commodities we might touch, I think the solution is the frequency and protecting yourself is the most important. You asked about whether asymptomatic people transmit. Although they are very few, I have said between 24 to 48 hours before developing the first symptoms of fever or cough, there is virus shedding recorded. That means there is transmissibility. So the risk is even before the symptoms are. But most of the cases happen after the person is symptomatic. So for one to shed as it is transmitted by droplets, coughing and becomes a major factor as well. Although this meeting is not on the subject of zoonotic disease, we are addressing zoonotic disease. I think let's avoid that discussion into another time.
Okay, the incident commander, keep it brief so that we can have comments from the rest of the panelists.
Thank you, Chair. My language is command language. And to start with, I'm evaluating this mass gathering. You have done well there, you are checking temperature and others, but okay, from this one person, we are all 30. So if I touch somebody, but I will not be hard on you, you are my teacher. So next time others have had. Okay, straight to the questions. One, human capacity from Dr. Kanyis, Professor Kanyis. Please, I need those people. And I need to state that every Ugandan, whether you are inside here or outside here, whether in the village, town, or anywhere, you have a role to play to prevent coronavirus in Uganda. And you need to play that role. So please, Professor, give me those that human capacity. Let them come even tomorrow, but they should come to volunteer and help their nation. And we fight coronavirus in Uganda. They should not come with a lot of expectations. The expectation is to work and give their utmost energy, as we also struggle here and there to make sure they are comfortable, but they have to work and serve and help this country out of coronavirus. 3, there was a question on contact tracing and follow-up. Yes, we are very cognizant of that. We have had enormous experiences, and we have engaged Red Cross volunteers. We have put sufficient manpower to enable on everyday basis to check on every high-risk traveler that is under self-quarantine. And if that person is found outside his home or house, then it means he or she has failed the self-quarantine, and we shall use other means now. It means you need to go into institutional quarantine at your own cost. So please, especially Ugandans, be aware of that. Please respect self-quarantine. We have the guidelines, we shall give you the guidelines, and we really wish that let everybody join hands and we fight this coronavirus. Okay, the director talked about the test kits and okay, the guidelines are here. Fine. There's something on engaging other politicians and partners. We have an interministerial committee on coronavirus headed by the Prime Minister, Right Honorable Prime Minister, and a number of ministries, MDAs that are involved in that interministerial committee, and they are doing their work at that level. So we are trying our best, but I think we have to really continue and sensitize as much as possible. Thank you.
Thank you so much, Prof. I think the question, although it was directed to me about the land border crossings, what we are doing at the Entebbe Airport and in regards to other agencies and other crossings, maybe someone will answer that. But DG, sir, maybe one thing I can pick from one of, I think, your staff about disinfection. Airlines are continuing to ask us of the measures that are available at the Entebbe Airport in regards to a case that may be brought in one of these aircrafts. what measures are in place to do disinfection. What I must say is that they are very cooperative. They are actually willing to give as much as possible in terms of equipment and maybe other support. But I think maybe that aspect through the national task team, I think it needs to be looked into and maybe position a team just like the surveillance team to see that in the
border, the question that was given to him was this.
The other entry points beyond
Yeah.
Okay.
We have instituted screening at other points of entry, including Busia, Maraba, Eleku, Pondwe, and Chanaka. Okay, all those are very active as I speak, and they are screening travelers from the neighboring countries.
Okay, thank you very much. It looks like we have a very, very active group online because we now have more than 20 sheets of papers with questions, and I think we are going to sort them out and see how we can respond. There is so much interest here for more information. Can we hear from the CDC country director on any one of the questions that you'd like to take on?
Thank you, and I think the colleagues have done a great job answering the questions. I would just make 2 points. The first is that, as others have alluded to, it's a very dynamic situation. It's a new virus. We're learning as we go. I think Dr. Jonas showed the early cases started in China, but the problem has really moved to other places like countries in Europe. And so I think what we do at the airport crossings, what we do in Kampala needs to follow what we're learning about this virus and where it's going. There was a question about partners and donors, and I think, yes, we are continuing to support, as I've talked about and colleagues have talked about, but I would remind you that you've heard from almost everybody on the panel, the most important thing are basic things like hand washing. A bar of soap is not expensive. Social distancing, so things like thinking about whether you need to have a big meeting, if you're going to have a big meeting or a mass gathering, how to keep it safe. And actually, whether coronavirus ever comes into Uganda or not, we've seen with other outbreaks that other respiratory infections and and other infections can go way down when people actually start practicing things they know they should do. So I would just urge everybody here that those, people sometimes think we need an expensive thermometer, we need a thermoscanner. Yes, we need some of those equipments in high-risk settings like airports where they have to screen a lot of people. But for most of the rest of us, the basic measures will do.
Thank you very much. I feel I need to say something here. I want to say that a number of concerns have been raised, looking at what point are we going to do this, at what point are we going to purchase equipment for them. The preparedness and response is not an event. Things are not happening at the same time. It is a process, and I want to emphasize that most of the concerns are going to be taken care of. For example, engaging the politicians. We've already, like Atek has said, we've already taken it to the highest level. We've briefed His Excellency the President, and he ordered the ministerial committee chaired by the Prime Minister. We have briefed Parliament, and we do expect the parliamentarians to take the respective constituencies, the ex-officials, the councils. We do expect them to take this information down where so taking, engaging other agencies like KCCA. I want to emphasize here that a number of agencies are members